specific protein, CBG, which is called cortisol binding globulin. A little part of it is also binded to transportin as we increase the level of cortisol. What that means is that when the level of cortisol is increased, we're expected to have a low lymphocytes in the blood and a very low eosinophil, with the consequence effects. Please, can we go to the next slide, please? In terms of distribution, well, because of the reporting line and the statistics that is currently available in Nigeria, it's not only in Nigeria, it is not cases that are reported in Nigeria, but it's fairly common, especially with the advent of COVID, which is one of the provocating factors. We'll still get to that when we talk about viral causes of ME. Well, it's fairly common in women. A lot of people have said because women tends to report their illness early. The causes basically is unknown, you understand, but it has been attributed to genetic and environmental reasons. In Nigeria, like I said, because of the reporting line, and that is one of the essence of this webinar, is just to create index of suspicion of most people will be coming down with a lot of things that are cardinal as in definition. So we must be able to put this and put it in our heads perspective so that we know what we are dealing with. The statistic that is recorded is about 100,000 cases per annum in Nigeria. In the US, we have about 2.5 million cases, mostly undiagnosed. And most times it lasts for years or even longer than that. And the medical diagnosis usually need to be, that needs to be done because you need to do a lot of cross-check. ME basically is an illness of an exclusion. When the patient comes, you understand, you need to screen that there is any other organ issues before you now make a conclusion that this is actually the case that you're dealing with. So in making that diagnosis, you need imaging and a lot of laboratory tests, especially when it comes to organ screening. Next slide, please. Risk factors. Well, I have said that sex is commoner in female than in male. Sometimes for the reasons that are previously adduced. The age, it occurs at any age, but it's commonly seen in the young to middle age. The good news about this age group is that once they have it, they tend to outgrow it. Understand? As compared to when it is happening later in life. Of course, one thing that has been strictly attached to it is genetics and environment. Genetics in the sense that there is tendency that when you have it in one family, they're likely to have it. There's going to be a family history of it, and then of course environmental factors. Environment that are well polluted, like we have in the world now. The pollution is from the virus that is ravaging the whole world now. So those are the factors that actually can be linked to it as a risk factor. Next slide, please. Well, causes unknown. Some are born with predisposition. That's why I talked about genetic, which is triggered by a combination of factors. And these factors are as follows. Number one is the viral infection. Most likely before the advent of COVID is infectious mononucleosis. It's very common in the developed countries, and that's where it's more reported that way. The immune system problem, you understand? And I've also talked about cortisol, how it does to reduce the immune system. So when you have a lot of cortisol, and that's why I say pregnancy and oral contraceptive pill tends to increase the level of cortisol. They have the tendency to trigger, they're all trigger factors. Hormonal imbalance, of course, we've said a little bit of this when we spoke about the physiology and of course, physical and emotional trauma. Wow. We're going to be talking about that in full as soon as we move on. Next slide, please. How do you make a diagnosis of ME? How do we make a diagnosis of ME? This can be details from the initial definition and the United States Institute of Medicine criteria, and they listed some conditions that we have to meet before we make a diagnosis of ME or chronic fatigue syndrome. The first one is the severity to the extent of interfering with ability to engage in pre-illness activity. And that is very, very important. When you have a fatigue that is so severe to the extent that it interferes with your pre-illness condition, you understand, with any ability to engage in pre-illness activities, then that's the first thing that qualifies it. Not substantially alleviated by rest. Naturally, when one gets tired and you say you want to, let me just take some rest. When you rest, in chronic fatigue syndrome, it's not that fatigue is not alleviated, and is worsened by physical, emotional, and mental exertion, and it's usually lifelong. But if all these above three has been on for about 6 months minimum, then it can qualify for a case that you can put in as chronic fatigue syndrome. Chronic fatigue syndrome. There is a lot of history that are behind this criteria, and I'll give them as soon as possible. Next slide, please. Now, to meet this criteria, the player needs to experience difficulties in memory, focus, and concentration. For instance, a patient comes to you, and you know that one of the challenges that he has explained to you is that he's having difficulties in concentrating and all that. Once you tell the patient your name and you would advise him that he should remember that you're going to ask in another 5-10 minutes along with the discussion, the patient may not be able to recollect the name. So that is, or when he is discussing, he can flip from one discussion to another. You understand? It's not really focused. You can easily see a patient that in that realm. Dizziness. This dizziness is when the patient wakes up, for instance. When he wants to move from the lying position to the sitting or standing position, there's tendency for the patient to feel dizzy. Of course, we all know that there are some drugs that makes people to be like that, but we need to rule out those drugs. These symptoms, like I said previously, must last for at least 6 months. These are the diagnostic criteria as defined by the United States Academy of Medicine. Next slide, please. What are the signs and symptoms that you see in chronic fatigue? From the definition, automatically you know there's going to be a fatigue. And the way to describe the fatigue is that it's been there for a period of 6 months. When you have an activity, it is worsening and it's not relieved by rest. So there must be fatigue. The second is that there will be pain. There will be joint pains, there will be muscle pain, there will be headache. The third is that you will not be able to do an exercise. Cognitives is that there will be confusion, there will be forgetfulness, there will be lack of concentration, there will be no focus. And sleep is either you have an excessive sleep or you have problems in getting to sleep, or when you sleep, you wake up early. And of course, if you have all this, it's an automatic card for an anxiety and apprehension. Those are the signs that are usually associated with chronic fatigue syndrome. Next slide, please. Treatment modalities. Now, let me give you a little bit of background of the treatment modalities of chronic fatigue syndrome. like we all know, once we have been given a guideline of a particular treatment, there's usually a challenge to change. In the UK, the patients are accusing doctors that they are insensitive to their plight, that exercise is not the solution to their problems for a long period of time. Because the treatment modality for ME or chronic fatigue syndrome basically has been the exercise theory, the graded exercise therapy, as well as the CBT, cognitive treatment. This has not helped at all. As a matter of fact, it has caused a lot of challenges in the health insurance because the doctors refuse to allude to their own thinking, but impressing their own treatment. But you know, medicine is actually changing. We're moving from doctor-centered to patient-centered kind of treatment, and that's why a lot of things has been going on. There's a literature on this that came out recently. That I think that was November 2020 during the COVID period in US. The theory, like the GET and the CBT theory, that is organic theory, was refuted in the US. The US have steadily lost ground in favor of the biomedical theory, and the biomedical theory is what people are trying. And this is a plus for the community pharmacists, and they can pass this to the industrial chemists, industrial pharmacists, to be able to produce a drug for this condition. There have been no medication directed at the illness, but there are drugs that have been directed at the symptoms that arises from the illness. And that's why treatment modalities, the first statement there is no cure or approved treatments for the chronic fatigue syndrome, but you need to symptomatically manage the condition. And the emphasis here is that you must attend to the most destructive or disabling symptoms first. And that is usually the pain. That's usually the pain. The pain can be relieved by over-the-counter drugs like ibuprofen, naproxen, and the rest of that. But you can also have prescription drugs like pregabalin, amitriptyline, gabapentin, and the rest. Now, I must emphasize at this point that once you have the impression that you may be dealing with a systemic exactional intolerance case, from day one, please let us invite the psychiatrist to manage this case with us. It is very, very essential because it's actually an illness basically in their purview. It's basically an illness in their purview, and they also need to bring in a psychotherapist and a lot of social workers, which is not fully established here, but they have the prowess to be able to manage this condition with us. For instance, depression sets in a lot, and it actually makes them to really socially alienate themselves. So you must be able to invite a psychiatrist to co-manage, who will start some drugs at a dosage that their profession allows, and you can manage it together over a period of time. Next slide, please. I have also mentioned the issue of orthostatic intolerance. So what that means is that the patient has been lying down for a while. You understand? Whenever the patient stands up, it automatically feels some dizziness. There are some medications that makes people feel like that. You have to be sure that the patient is not on such medication, and at the same time, you need to use a drug that will control the heart rate of the patient appropriately. Counseling, psychotherapists, this is where I've also said that it's important that you invite, when you invite a psychiatrist, we'll be able to know when all these things will be needed in the areas of sleep and in the area of exercise. They are very, very important. Supportive therapy. This is not fully grounded in Nigeria, but we need to start developing it. And that's one of this accusation. A physician must be able to develop an empathy for the patient and see that it supports them and bring the family to support. The issue of a treatment support group is important, especially when it comes to appointment. For instance, you give a patient to see you in 2 weeks. You understand? In between that, he has some complaints. But by the time he's reporting in 2 weeks, he had forgotten. But when you have a treatment support group, you'll be able to come with the patient and remind the patient the time and some of those signs and symptoms that actually occurred that were not there when the first appointment. So it's always very, very good to have a supportive treatment plan. Understand? Next slide, please. Next slide. Well, the next slide is basically on the complications, of chronic fatigue syndrome. Lifestyle restriction. Obviously, this kind of patients totally would be, the lifestyle would be different. He cannot do anything without pains. He has headache, he cannot concentrate, he cannot go to work, he cannot think. There will be a lot of social isolation. He's always lying down. Of course, when the patient is depressed, of course, you know what that means. And of course, we know how we always try to stigmatize illness here. Once you say a patient is having depression, you understand, the mindset is that it's mad. You understand? And of course, we know the history of depression in this country. All professionals are getting depressed. COVID has made a lot of people to be depressed. Economic world is not fair on anybody. So there's quite a lot of depression that is around that the psychiatrists can work on. Of course, when you have this kind of a thing, it will automatically take you away from your daily work activity. So there will be a lot of absenteeism from school, from work, from other. And this is why I said it's a very good reason to get the psychiatrists involved from day one. Just like we always say, when you have a CVA case, a stroke case, please always try to involve the physiotherapist. The same thing we say to chronic fatigue syndrome. Please let us involve the psychiatrist in the management of this case. Before I go away, it is a challenge globally. Chronic fatigue syndrome is a challenge globally. But it's important as a general practitioner that we must be able to create an index of suspicion when we have cases like this, so that we will be able to link our network with the psychiatrists. We cannot work in isolation. We are a gateway doctor. We're a gateway to so many professions. So when they come in, you understand, we're supposed to see and decipher where next the patient will get a second care of services. I want to thank the organizers of this program, Mega Life Science, for giving us the opportunity to come and share the brief that we know is the upcoming illness, and I'm very sure in a short time everybody will be aware of it when we continuously create that awareness. The sponsors of this program, thank you very much. Dr. Link, thank you for inviting me, and I'm going to be listening to Prof to put more literature into what I've said. Thank you very much, and God bless you.
Thank you, Dr. Akintade. Thank you so very much for that in-depth knowledge you've shared with us. You've given us the definition, the symptoms, the treatments, as well as the complications of chronic fatigue syndrome. Please, if you have any question, kindly post in the Q&A section after the whole presentation. Dr. Akintade will still be standing by to answer any question you might be having. So right now we're going to be having Professor Lateef Sheikh to give us his own presentation. Thank you very much.
Thank you very much for giving me a space to participate in this presentation. I also want to thank Dr. Akintade. Can you hear me?
Very well.
I can hear you, sir.
Okay, I also want to thank Dr. Akintade for his very erudite presentation. He has shed a lot of light on the chronic fatigue syndrome, and he's made my job a little bit easy. I will be able to skip a lot of slides that I already prepared because he has done justice to most of those areas. So I want to thank Mega Life again for inviting me to this forum to talk about the mental health aspect of chronic fatigue syndrome. But before I go on, I will. I have a video, a 1-minute video that I would like you, Tife, to share. Let's watch it. Let me just give you a background. It's a kind of frustration that patients who have chronic fatigue syndrome do encounter when they go to hospitals and doctors tell them that you are not sick, you don't have a problem. So please, I'd like you to play this video for us.
Chronic fatigue syndrome. That is a real illness. You can. Dr. Bud? Yes. You probably don't remember me, but you told me I wasn't sick. Do you remember? You told me I was just getting old. Sorry, I really don't remember. Maybe you're getting old. That's a little joke. Well, I tell you, Dr. Bud, I really am sick. I have chronic fatigue syndrome. That is a real illness. You can check with the Center for Disease Control. Oh, well, I'm sorry about that. Well, I'm glad. At least I know I have something. I'm sure. Well, nice seeing you. Not so fast. There are some things I have to say. There are a lot of things that I have to say. Words can't express what I have to say. What I went through, what you put me through. I can't do this in a restaurant. Good. But I will. Louis, who is this person? Look, miss, sit. I sat for you long enough. Dr. Bud, I came to you sick and scared, and you dismissed me. You didn't have the answer, and instead of saying, I'm sorry, I don't know what's wrong with you, you made me feel crazy, like I had made it all up. You dismissed me. You made me feel like a child, a fool, a neurotic who was wasting your precious time. Is that your caring profession? Is that healing? No one deserves that kind of treatment, Dr. Bud. No one. I suspect had I been a man, I might have been taken a little bit more seriously and not told to go to a hairdresser. Look, I am not going to sit here anymore. Shut up, Louis. I don't know where you doctors lose your humanity, but you lose it. You know, if all of you at the beginning of your careers could get very sick and very scared for a while, you'd probably learn more from that than anything else. You'd better start listening to your patients. They need to be heard. They need caring. They need compassion. They need attending to. You know, someday, Dr. Bud, you're going to be on the other side of the table. And as angry as I am, and as angry as I always will be, I still wish you a better doctor than you were to me.
Right. Thank you very much for sharing that video. It depicts the kind of frustration that patients go through when they are suffering from this condition. I would like to now share my slide. Can we all see the slide?
Yes, sir, we can. Yes, sir, we can, sir.
Okay, thank you very much. So patients who have chronic fatigue syndrome many times go unrecognized, and they are dismissed by the doctors who see them. And that further heightens them, it makes them more anxious. They become very afraid. They think that they are going to die. Even the doctors don't know what is wrong with them. So it's a very serious matter, just like you watch in that video. This is the outline of my presentation. I'll introduce it. Dr. Akintade has talked about the definition, the criteria, aspects of etiology. I'll just brush a little bit what affects, what is related to mental health in those areas. And then I'll talk about the relationship between chronic fatigue syndrome and mental health, and what's our approach to care, and what lessons have we learned today. So ever since, sorry, please. Yes, ever since neurologist George Miller Beard coined the term neuroasthenia in the 19th century, dozens of names have been used to describe this illness that resembles chronic fatigue syndrome. The diverse nomenclature reflects heterogeneity in the diverse conceptualization of this condition. To the extent that it's been given all sorts of names. People have called it Epstein-Barr virus syndrome, epidemic neuromyasthenia, systemic exertion intolerance disease, post-viral fatigue syndrome. Today, people call it myalgic encephalomyelitis, or people also call it chronic fatigue immune dysfunction syndrome. So there are so many names that people, and today this keeps changing and changing and changing, and I believe we are still not fully there yet, because just like Dr. Akintade said, we have named a condition without actually knowing the true picture of that condition. We also know that the diversity in the nomenclature parallels the diversity in the therapies assessed for this frequently refractory cluster of symptoms, which include pharmacological, psychological, and lifestyle approaches to treatment. You heard Dr. Akintade talking about exercise, and that people are now shifting away from use of exercise alone, that exercise can be used together with some other forms like pharmacological and psychological approach. Increased rates of psychiatric disorders have been reported in those diagnosed with CFS or ME, although the direction of the causation in this relationship has not been well established. Even the cause of the illness has not been well established. You heard that from Dr. Akintade. Dr. Akintade has talked to us about the diagnostic criteria, and I think he has exhausted that. Significantly, part of it is that the condition is worsened by physical, mental, or emotional exertion. And that is why he talked about the influence of COVID on this condition. Whatever that is going to create some exertion on the individual, whether emotional or mental, the fear of COVID itself could make people who have tendency to develop chronic fatigue syndrome to manifest it. So these are the criteria which Dr. Akintade has actually talked about. He also talked about the etiology. And of course, the cause of the chronic fatigue syndrome is unknown, like he said, although there are many theories ranging from viral infection to psychological stress. Some experts believe chronic fatigue syndrome might be triggered by a combination of these factors. I must also emphasize that there is no single test to confirm a diagnosis of chronic fatigue syndrome. Variety of tests are required to actually rule out other health problems that have similar symptoms. So it's a kind of diagnosis by exclusion. But I want to let you know that it's been shown that patients with chronic fatigue syndrome have decreased activation of the basal ganglia in response to reward. Additionally, the extent of this lowered activation was associated with each patient's measured level of fatigue. I also want you to know that the abnormality in basic ganglia, basal ganglia, can also be found in patients who have schizophrenia and some other mental illnesses. And there goes the relationship between chronic fatigue syndrome and mental illness. So how do we relate them actually? We do know that there are high levels of depression. There are high levels of depression and anxiety that are experienced alongside chronic fatigue syndrome. Now it's about which one comes first, the chicken or the egg. Do we have these conditions before chronic fatigue, or is it chronic fatigue that is leading to this condition? But we do know that they coexist, and we do know that they need to be addressed. Amelia Wright et al. In their own study shows that there is maladaptive perfectionism that is consistently associated with depression in patients with chronic fatigue syndrome. And that chronic fatigue syndrome without depression, we are no more likely to have illusionary mental health compared with healthy controls. Among the chronic fatigue syndrome without depression, illusionary mental health was associated more with physical symptoms. What we mean by illusionary mental health problem is people who deny the existence of such mental health. Like Dr. Akintade said, they don't want to be said to have depression. If somebody says they have depression, they will say that they are running insane, they are mad. So they struggle, they defend themselves from accepting that they have certain mental health symptoms. And such people tend to come with more physical symptoms as compared to others who accept the presence of such mental health conditions. They concluded that their findings refute reducing chronic fatigue syndrome to somatization. But there is a subgroup of chronic fatigue syndrome whose lacking access to emotional distress is associated with heightened physical symptomatology. Harvey et al., in their work on the relationship between psychiatric disorder and chronic fatigue, evidence from a national back cohort study that was conducted in the United States reported that 1%, about 1% among over 3,000 subjects that they assessed at the age of 53 reported the diagnosis of chronic fatigue syndrome. And that chronic fatigue syndrome was more common among females. But there was no association between chronic fatigue syndrome and either social class, social mobility, or educational level. They also showed that those with psychiatric illnesses between the ages of 15 and 36 were more likely to report chronic fatigue syndrome later in life, with odds ratio or adjusted for sex to 2.65, with 95% confidence interval, as you can see there. They also reported that there is increased levels of psychiatric illness, in particular depression and anxiety, were present prior to occurrence of fatigue symptoms. There was a dose-response relationship between the severity of psychiatric symptoms and the likelihood of later chronic fatigue syndrome. Personality factors were not associated with a self-reported diagnosis of chronic fatigue syndrome. They concluded that this temporal dose-response relationship suggests that psychiatric disorders or shared risk factors for psychiatric disorders are likely to have an etiological role in some cases of chronic fatigue syndrome. Neuro Watanabe et al., in their own work on the epidemiology of chronic fatigue, physical illness, and symptoms of common mental disorders, a cross-sectional survey that was carried out during the second British National Survey on Psychiatric Mobility, reported that the prevalence of chronic fatigue was 15%, and this showed a significant association with the number of reported physical illnesses. They also showed that it was higher in midlife, in women, and in participants with less skilled occupations, and in those with lower educational attainment. Chronic fatigue was strongly associated with the presence of depressive symptoms, anxiety-related symptoms, and sleep complaints. They showed that after the adjustment for all social, demographic, and psychiatric factors, the number of reported physical illnesses was less strongly, but still significantly associated with chronic fatigue, and that physical illness is strongly associated with chronic fatigue. Symptoms of common mental disorders are also associated with chronic fatigue. Association between physical illness and chronic fatigue is evident even after adjusting for psychiatric symptoms. The assessment of physically ill people should include chronic fatigue and psychiatric symptoms, they asserted. In conclusion, they said that physical illness is strongly associated with chronic fatigue. Symptoms of common mental disorders are also associated with chronic fatigue. But the association between physical illness and chronic fatigue is evident even after adjusting for psychiatric symptoms. The assessment of physically ill people should include chronic fatigue and psychiatric symptoms. That's their conclusion. Maria Laudis et al., in their work on the presence of morbid mental health problems in cohorts of adolescents with chronic fatigue syndrome in the United States, reported that on the psychiatric interview, 34.6% met a diagnosis of major depressive disorder, and 28.8% had anxiety disorder. Of these, 15% had comorbid anxiety and depression. Those with a depression diagnosis reported significantly greater interference in school and social adjustments. They also scored significantly higher on trait anxiety, but not on state anxiety. They reported that there were no differences between those whose level of anxiety disorder and those who did not on fatigue, excuse me. They reported that there were no differences between those who have anxiety disorder and those who do not on fatigue, disability, or depressive symptoms. Children's depression inventory in CDI score was associated with a depression diagnosis on the psychiatric interview. However, neither the state nor the trait subscale of state trait anxiety inventory was associated with anxiety diagnosis. They therefore concluded that clinicians should assess for the presence of anxiety and depressive disorders in adolescents with chronic fatigue syndrome using a validated psychiatric interview. Treatment should be flexible enough to accommodate fatigue, depression, and anxiety, so they concluded. So what are the possible complications of chronic fatigue syndrome? We do know that chronic fatigue syndrome could affect lifestyle, so it could lead to lifestyle restrictions. We also know that chronic fatigue syndrome could lead to increased work absences. It could lead to social isolation. And we have heard now that it could lead to depression, anxiety, and our greatest fear is that of suicide. What is our approach to care for patients who have chronic fatigue syndrome? Chronic fatigue syndrome is a manageable condition, even though in most literature that we have gone through, they say that chronic fatigue syndrome is not curable. But I don't like that idea. I don't like talking about curable, being either curable or not, because today we all know that even malaria is not curable. It doesn't mean that if you have malaria today, it will not come back tomorrow. So we know that chronic fatigue syndrome runs a chronic course. It is manageable. People can remit, and they can come back with the condition in later in the future. Like Dr. Akintade said, our treatment must focus on symptom relief, and the most destructive or disabling symptoms should be addressed first. And like he said, usually pain is the most disabling symptoms. Our approach to care should include use of medications, psychotherapy, rehabilitation therapy, They are all useful in the care for chronic fatigue syndrome. How do we manage depression, anxiety, and orthostatic dizziness that is associated with chronic fatigue? Depression and anxiety could commonly complicate chronic fatigue, as we have heard. Treating with appropriate antidepressants, starting with low-dose tricyclic antidepressants like amitriptyline, tends to work. We can then progress to the selective serotonin reuptake inhibitors like fluoxetine where necessary. Orthostatic intolerance, which is characterized by persistent dizziness. In some people with chronic fatigue syndrome, particularly adolescents, feeling of fainting or nauseated when they stand up or sit up from upright is a major problem. So medications that tend to regulate blood pressure and some that control heartbeats have been found very useful in managing this very disturbing symptom. How do we manage pain? The non-steroidal anti-inflammatory agents like ibuprofen and naproxen are still quite useful in this case. But we must be very careful because of the reported cases of the reported effects of non-steroidal anti-inflammatory agents associated with COVID-19 infections. So we need to be very careful about that. Medications for fibromyalgia that we know have also been found to be very useful in managing pain in patients with chronic fatigue syndrome. Medications like pregabalin, duloxetine, even amitriptyline and gabapentin have been used where patients don't respond to non-steroidal anti-inflammatory agents or in situations where they are contraindicated. Psychotherapy. You've heard what Dr. Akintade said. Psychotherapy is very, very valuable in patients who have chronic fatigue syndrome. Many people with chronic fatigue syndrome benefit from counseling, and counseling can be given by anybody who has some basic medical knowledge. Pharmacists, primary health workers, doctors, nurses, they can offer counseling. This is not reserved only to psychotherapists, not only to the psychologists. Talking with a counselor can help build coping skills to deal with chronic illness, address limitations at work or school, and improve family dynamics. It can also be helpful for managing depression. Cognitive behavioral therapy has been found to be very useful, and I do attach a lot of references on successful use of cognitive behavioral therapy in chronic fatigue syndrome, which will be shared to you. Cognitive behavioral therapy is an evidence-based treatment for chronic fatigue syndrome. Stepped care for chronic fatigue syndrome, consisting of minimal intervention followed by face-to-face CBT, was found to be very efficacious when tested in a chronic fatigue syndrome specialist center. Addressing sleep problems is also something that is very, very important in people who suffer from chronic fatigue syndrome. Sleep deprivation makes other symptoms more difficult to deal with. So we know doctors can suggest that you should avoid the use of caffeine or address some sleep hygiene, including bedtime routine, in people who have significant sleep problems. Exercise has also been in fact, exercise was initially a mainstay regimen in the management of chronic fatigue syndrome until now, when we now approach the biopsychosocial approach to the care, biological, psychological, and social. Aggressive exercise regimens often lead to worsening of symptoms, so we need to be very careful. So even if you are going to recommend exercise, you have to be very careful. But maintaining activities that are tolerated is important to prevent deconditioning. Exercise regimen that start at a very low intensity and increase very gradually over time may be quite helpful in improving long-term function. So what are the lessons that we have learned today? First, we do know that the cause of chronic fatigue syndrome is not known. And we know that etiology ranges from viral infection to psychological distress, and it might be triggered by a combination of these factors. We have also known that the condition could be managed. Treatment should focus on symptom relief, and that the most destructive symptom or disabling symptom should be addressed first. We have also known that there is no single test to confirm a diagnosis of chronic fatigue, and that diagnosis is mainly by exclusion. We've learned today that clinicians should assess for presence of anxiety and depressive disorders in patients with chronic fatigue syndrome using a validated psychiatric interview. You've heard what Dr. Akintade said, and let us keep remembering that the mental health workers are very important in the care for patients with chronic fatigue syndrome. We've learned that treatment should be very flexible enough to accommodate fatigue, depression, and anxiety, and that such treatment should be multidisciplinary and transdiagnostic in nature. And these are the things that will suit this purpose. We also have known that goals should include pleasurable activities, particularly for those who are depressed. So with this, I've come to the end of my presentation, and I hope that we have been able to pick a few things from this presentation. I want to thank MegaLife, DocuLink, for inviting me to give this presentation. Thank you very much for listening.
Thank you so much, Prof. Thank you so much. This is a very in-depth analysis about chronic fatigue syndrome. We've learned, I love the part where you were able to summarize in case maybe some of us get lost in all the, studies and all that, where you're able to give us in a very, very short time the few words to take home, our take-home messages from the unknown causes of chronic fatigue syndrome to the management, okay, as well as no single test to confirm the diagnosis. So, and also what I'm able to take home is we should do everything in moderation, from exercise to all. We should just try and maintain moderation in everything we do. Thank you so very much. Please kindly be reminded that you should post your comments, your questions in the Q&A section. Prof will be standing by to answer your question. Dr. Akintade is also still here. He'll also be answering the question at once. So I will be sharing my slide now to do a little product presentation from MegaLife Sciences. So please kindly stand by so we enjoy the presentation. So once again, my name is Matti. Okay, I'll be talking to us about our dependable friend in time of stress. We've heard a lot about stress. We've heard a lot about fatigue. We've learned a lot on how we should manage chronic fatigue syndrome. But all these things then happen. Chronic fatigue syndrome didn't just happen overnight, like we heard or we've learned. Chronic fatigue syndrome takes time, and it happens when things are not being taken care of, when stress is not being attended to. So just give me a moment. I'm trying to share my slide, but I'm having a bit of technical issue here. Just give me 2 seconds. I'll be sharing it shortly. Okay, I hope we can all see my slide now. Thank you very much. Like I said, we've heard a lot about stress. We've heard a lot about fatigue. So from the stable of MegaLife Sciences, I'm bringing to us a dependable friend in stress, general well-being, and immunity. Ginsomine is our brand of ginseng, selenium, and multivitamin. Ginsomine is a product that helps to reduce the cortisol level in the body, because ginseng is a product, or is named or is tagged a product that helps in reducing fatigue and stress in patients. And ginseng is a product that has been widely researched in terms of reducing the cortisol level in patients. Sorry, just give me a few minutes. My system. Okay. All right. Yeah, thank you so much. So in general well-being, we have quite a lot of things that can affect our well-being. We've heard a lot about sicknesses when left for a very long time unattended to. All these can deplete energy and nutrients in the body. Chronic stress also affects general well-being, performance, and immunity. Sometimes the vagaries of life also take its toll. Dr. Akintade mentioned COVID-19 as one of the things that is causing depression, and Prof also mentioned it in his statement. We also talk about oxidative stress, which is also a common link in all these, in depleting the body of its energy and vital nutrients. Yes, there are things that can help us improve our well-being, from eating good food, which includes our fruits and vegetables, to getting adequate exercise. Prof mentioned that we should do things in moderation. So strolling or walking, you don't have to lift that 250 kg. Just brisk walking for 30 minutes could help improve our general well-being. Living well with the support of family and friends. We've heard about depression, but when you have people of goodwill towards you, around you, this could help us improve our well-being. Also, as well as living in a clean environment is something also that can help us live a good life. But sometimes we do not get enough of these nutrients in our diet, okay, due to, we have several reasons, from ignorance, overboiling that denatures important nutrients in the food. Sometimes poverty also could be a factor, you know, as well as the increased demand in nutrients in the certain condition. When you have a patient that is, you know, having comorbid, you definitely have increased demand in nutrients in such patients. Now, the immune functions in so many ways. We have the antibody-antigen reaction, you have the phagocytosis, you have the thymus gland stimulation, you have the cell-mediated inflammatory response, you have the signaling of messenger protein, but you have some vitamins and micronutrients that contribute to good health, also immune function. Things like antioxidants, which you're talking about selenium, vitamin E, which is fat-soluble vitamin. Then you have zinc, you have beta-carotene, the natural, not synthetic beta-carotene. You have fat-soluble vitamins, like I mentioned, vitamin E, vitamin A, and vitamin D. Then you also have water-soluble vitamins, as well as trace minerals. Here I present to you ginseng to help with good health every day and for performance, vitality, and protection. Ginseng contains ginseng, like I mentioned earlier, antioxidants such as selenium, natural vitamin E, vitamin A, and vitamin C, other vitamins and minerals. We've heard that ginseng increases the body's resistance to stress. How? Ginseng is an adaptogen, is a steroid-like phytochemicals, and have adaptogenic property which counter the effect of stress. Dr. Akintade and Prof has mentioned that stress increases the cortisol level in the body, but ginseng, which is an adaptogen, helps to counter the effect of this stress. Ginsenoside also increases protein synthesis and activity of neurotransmitters in the brain, which ultimately helps to increase energy level. Patient is active and alert throughout the day. Then at night, you're able to sleep well. Ginseng improves overall well-being and performance. How does it do this? By helping the body cope with the effects of diseases and stress by preventing cell damage that causes wear and tear on the body. Ginseng, like I mentioned earlier, contains ginseng, 11 vitamins, and 9 minerals. Now, the daily stress on women, because we saw in Prof's presentation that the women are the most affected when it comes to chronic fatigue syndrome. And this is just very typical because sometimes women are too busy taking care of others that they don't remember to take care of themselves. So I present to you Ginsomin Eve, which is a comprehensive women's health formula, because Ginsomin helps with vitality, healthy skin, strong bones, and immunity. Ginsomin Eve also contains ginseng as well as Ginsomin 40 milligram. Ginseng, we all know in women, or studies have shown that ginseng extracts improve sexual arousal in menopausal women. Ginsomin Eve also contains grapeseed extracts, evening primrose oil, hydrolyzed collagen, oxtail extract, selenium, as well as ginseng. Grapeseed extract, you might be asking, what is it meant for? Grapeseed extract are industrial derivative from whole grape seed that helps, it has high concentration or great concentration of vitamin E, flavonoid, linoleic acid, which are antioxidant properties. Evening primrose oil, we know that is a well-studied product that helps women. It has become a standard part of recommendation for maintaining youthfulness in women and preventing disease in women, as well as treatment for aging problems such as that of menopause. Hydrolyzed collagen also helps to improve the luminosity of the skin by promoting a healthy looking skin. Aging process is associated with loss of collagen, so therefore it's needed for supplementation. So as women ages, they need to take a supplement that will help improve the luminosity of their skin. And oxtail extract is also, it contains silicone, which plays an important role in strengthening the bone. And we've also seen that a lot of study has shown us that as women age, they come down with osteoporosis. So when we say Ginsomin Eve contains, is a comprehensive women's health formula, we mean it's an all-round thing. So who should take Ginsomin Eve? Women who are living an active lifestyle, women who wish to preserve their beauty, vitality, and good health, women who are beginning to approach menopause, women also who are postmenopausal, to slow down the aging process. Now, the caution for Ginsomin and Ginsomin Eve is uncontrolled hypertension. Any patient that is not taking their hypertensive drug or their blood pressure is not being controlled, thank God today is the World Hypertensive Day. So if your patient does not have their blood pressure under control, they shouldn't take Ginsomin or Ginsomin Eve. Seizure disorders such as epilepsy, pregnancy, and breastfeeding mothers should not take Ginsomin and Ginsomin Eve. Then surgical patients requiring anesthesia should also stop taking Ginsomin Eve 2 weeks before surgery. And patients taking thiazide diuretic should not take Ginsomin Eve. Instead, they can take Ginsomin. Then patients who are having heart or kidney disorder, gout, should not take Ginsomin Eve. They should take Ginsomin. Patients on antidepressants, we've also heard a lot about antidepressants in case of patients that are coming down with depression. So those patients should be advised to take Ginsomin rather than Ginsomin Eve. And patients to ensure adequate hydration. There are quite a number of studies that have shown that Ginsomin and Ginsomin Eve helps improve overall well-being, help improve sexual performance, help improve body resistance to stress, as well as help improve physical performance in patients. These are some of the studies that have shown ginseng helping erection in both male and female. So doctors, pharmacists in the house, kindly give your patient the Ginsomin and Ginsomin Eve advantage to the aging population who desire good health every day. All the long distance drivers who are stressed and fatigued, please give them Ginsomin, Ginsomin Eve. All the sufferers in Nigeria, all these people suffering from stress. Stress is everywhere in this country. So we need to help our patients to give them the ginsomine advantage. Men with low libido, premenopausal women, we're thinking about the executive, the entrepreneur. These are things they don't talk about. Like we've heard from Dr. Akintade and Prof, that no one comes to tell you that they are stressed, or you would not even want to listen to someone when they say they are stressed, but this thing is eating deep into our society. So we need to give our patients the ginsomine and the ginsomine Eve advantage. Like you can see in our on the slide right now, this is where typical people, our patients are living, are coming from. This is a picture from Lagos. Okay, this is Mushin, this is Obalende. That's where our patients come from. That's where they go to every day for businesses or for anything. Or if you say you're not found there, this is a typical Maryland bridge, okay? For those of us that lives in Lagos, and you have to go through this from morning and evening. And this is where some of us eat and sleep or wake up or do our businesses, very dirty environment. So we can see reasons why each and every one of our patients needs ginsomine and ginsomine Eve every day. Ginsomine is taking 1 capsule daily with breakfast, and it's taking for 2 months, after which you give a week of wash-up period, then you can continue. Thank you so very much. I'll stop sharing, and we have some questions right now at the Q&A section. And I want Dr. Akintade, there's a question for you. They are asking, what is the role of nutrition in chronic fatigue syndrome? That is coming from Dr. Semiu. Dr. Semiu Olagodin here.
Yeah, thank you very much, Dr. Semiu Olagodin. That's a doctor from Abuja. Like we have actually linked, and I'm glad that Prof has actually collaborated a lot of things that I've said. If we know that stress will cause a lot of cortisol in your body, and I've also emphasized that cortisol has the tendency to reduce lymphocytes. Lymphocytes, of course, when we have a viral infection, you know your lymphocyte is very, very high. But when you have a lot of cortisols in your blood, you understand it will be low, and that is not protective against virus. The same thing goes to eosinophil. This actually reduces a lot of body immunity, and of course expose you to infection. So the role of nutrition basically is to address the issue of protecting you against the infection, increase your antibody, your immune system. And so we cannot overemphasize the role of nutrition. And that is very, very essential in any illness disease, in any illness that we can talk about. The role of nutrition is very, very important, more especially when it's attacking the hormonal and immune system. You understand? There's tendency for you to, when you're depressed, not to eat. You will not even talk to anybody. You'll be socially alienated. So there is a reason for you to have a supplemented feeding. You understand? And that's why it's important that the food is we take particular attention to strict meal, reduce oxidative process, and that's why you should take a lot of antioxidants and all that, and you should be able to improve your immune system. And that's the link that they have.
Thank you so much, Dr. Akintade. I hope, Dr. Semi, your question has been answered. You have another one from Solomon Ido. I would like Prof to answer that. That since treatment should focus on symptoms, for how long can the patient be on pregabalin, especially since it's not a one-off medication?
Well, it's recommended that you don't place patients on treatment for life because, like we have had during this presentation, it's waxes and wanes that can be pushed out by either physical exertion or emotional exertion either even illness, viral illness, bacterial illness. So these things will come and go. So it is to treat when the illness is active. So if you place somebody on pregabalin, usually once you have been able to get remission, all the pains are gone, the mood is better, she's active, she goes to work, she's returned to her premorbid level of functioning. I don't think you should maintain treatment for more than 6 weeks after that. Once you have achieved a complete remission, maintain treatment for more than 6 weeks.
Okay. Thank you so much, Prof. From Solomon Ido, I hope your question has been answered. There's another one for Prof here from Professor Musa Dankiel. We are so honored to have you here, Prof. Prof says that, thank you for your presentation. Are there any validation study regarding the diagnostic criteria for chronic fatigue syndrome in Nigeria? Then second question would be, this would be interesting, especially in view of the local understanding of the term fatigue. So Prof, over to you, sir.
Thank you very much, Professor Ankel. He's my guy, you know. So I'm really happy that he's on and listening to my presentation. So I hope you will give me a pass mark. You know,
definitely.
Well, to my knowledge, there is no validation study that I have come across regarding chronic fatigue syndrome. But I know that people have done a lot of work on burnout, which is also a little bit similar to chronic fatigue, but not this. There are similarities in some of the symptoms and in some of the approach to care, but they are not the same. Specifically for chronic fatigue syndrome, I have not come across a validation study that has been done, but Professor Dankiel may know because it's his area, he's an expert in this area. So he may even want to further educate us on it. What's the second question?
The second question is, he said, it's not a question actually, he said this would be interesting, especially in view of local understanding of the term fatigue.
Yes, because like I said, especially the video that we show, 1-minute video, patients they are not comfortable when they come to your clinic and you tell them that go home is just fatigue. They feel disappointed. They feel that you are treating them like they are acting out, like they don't have a problem. They abandon their job to come and line up in the clinic to see you, and you are telling them, go home, you don't have a problem. Go home, you have fatigue. So we have to be careful the way we use the word fatigue in this manner. The way our own patients will understand what we mean, that this fatigue is a fatigue of illness. It's not just fatigue of tiredness, that you are actually sick and you need help, and the help is around, available, and will be delivered to you. So patients need to come to terms with that, and doctors need to know how to talk to patients and know how you can hear telling that doctor that you should listen to us, listen to we patients, listen to what we have to say. So we should adapt that to listen to the patients, to hear what they are saying, to show some compassion in the way they have brought their problem to us, to put ourselves in their shoes, to be able to have a full understanding of their problem. So that's the way I see it.
Okay. Thank you, Prof. We have a question for
Well, I think, hello.
Okay, yes, sir.
Yeah, let me actually corroborate Prof's whatever. I think one thing that has been an additional information that Prof has actually added, especially for the doctors, is the issue of the basal ganglia, and we should keep on looking at that. It is very, very relevant, even though it is in their purview to do a lot of research. But somebody has asked, is there anything that we are doing in terms of advocacy? We need the first advocacy that we need and to really emphasize is making a mental health an issue. doctors, medical personnel are jumping inside the river. We should not wait till then when it will get to the leaders, the rulers of this country, before we put the advocacy to them. And it is the responsibility of all the health workers. We must join in the advocacy. Prof had actually told us before that this month is actually awareness on mental health. When we get to October, we're not going to be talking about it. Nobody, in the developed countries, they will put pressure on government, and government will increase the funding on research on drugs. I've also said that the pharmaceutical, those pharmacies should just also be awakened. They need a lot of time to go and research into medication. And again, I need to also emphasize that treatment, patient is getting more enlightened, and patients, the treatment pattern has moved away from from doctor-centered to patient-centered. And that video has clearly pointed that out. I'm glad, Prof, that video has been on for about, I think I saw the video first 2018, and the lady met a doctor at a restaurant, and you can see even the wife of the doctor asking to keep short and sit down and listen, because that is one of those problems. We must be able to adapt. And I'm also putting this to the psychiatrists. Please extend more hands of fellowship to the general practitioner. We need to collaborate. A lot of patients that are supposed to be discharged to the general practitioner and also to be referred from general practitioner to this. We have not opened that value chain line. We need to open it. We need to do an advocacy together towards ensuring that there are quite a lot of things that patients can benefit and they can value the health system. That is what I needed to add to what Prof has actually said. I don't know if that question will still come.
Thank you, Dr.
Before I interrupted
Akintade.
you, there was a question you wanted to. Yeah.
Yes, it was from Mr. Ahmed Ibrahim. He's asking a scenario in which maybe some patients with mental health or chronic fatigue syndrome problem, when their doctor prescribed drugs for them, and they will say they have used it before. So how are they going to be counseled? How can you counsel such patients? That's the question.
Well,
yeah, well,
thank you very much.
Counseling basically, like Prof said, okay.
Go ahead.
Please go ahead, Prof. Go ahead, Prof.
No, go ahead. You've started.
No, no, Prof. I ceded that to you.
Go on,
please.
go on. Please, go. I will add. Go on.
Yeah. Okay, fine. Thank you. You see, Prof said that we should not actually put counseling to the hands of the psychiatrist alone. Yes, I agree. You understand? But you see, there is a process. I'm a family physician, and I know there's a process of counseling. You understand? You don't load your ideas on patients. If you listen carefully to your patient, you will get an answer, because the patient on his own is also a consultant of his body. He knows what he knows. You understand? So basically, one should be able to listen, let the patient have confidence in your management. That is what is essential, not only in CFS, but also in other health issues. You must be able to get the attention of your patient and let them have confidence. There are quite a lot of drugs. I have a patient, when you give a particular brand, and that brand has been working, go and bring another brand, even if it is better brand, the patient will not collect. You understand? That means the patient have a belief in that particular drug. And for you to be able to defreeze that information and add another thing, it takes a lot of time. So the counseling section is a regular section. And if you look at our slide, both mine and that of Prof, it shows a lot of group support. You see, counseling is not only done in the consulting room, because you don't even have the time. You have a support group, you have a lot of patients. When they ask you to come and you have a group, you have a 4, 5, 6 team of members that have the same condition, you tend to learn more and understand that you are not alone in this system. System. So counseling is something that should be known and learn over a period of time on how we're going to do it. So I await what Prof is going to add, and we'll learn also from that.
Yes, thank you very much, Dr. Akintade. And I want to thank Mr. Ahmed Ibrahim also for this question. It's a very valid question. I agree with you that for you to be a counselor, you need the skill. But I also know that once you are a health worker, it's not difficult for you to acquire that skill. I am an advocate of integrating mental health at all levels of healthcare delivery. I have done a lot of work in integrating mental health into primary care in this country. And our mental health policy for Nigeria 2013, which is expected to be revised soon, and also the proposed mental health bill, is hinging mental health practice in Nigeria on integration of mental health at all levels. And for you to be able to integrate mental health, you must be able to do some tax shifting and tax sharing. Tax shifting to those who are not very knowledgeable, and tax sharing to colleagues like you who are doctors and nurses. We have to share the task. So we don't have enough psychiatrists or clinical psychologists, but we have people who can easily acquire this skill. And I believe all health workers could acquire the skill of counseling. It's not very difficult. And one primary ingredient to be able to deliver good counseling is to listen. Like you rightly said, we must be able to listen. Counseling is not overloading yours on another person. Counseling is laying it bare to give the patient an opportunity to make informed decision, to be able to choose what he wants. You lay it bare for the patient. So for instance, this patient that is saying that he has used this medication before. Yes, I agree we have used this medication before, but do you know other medications that are being used, and do you know the kind of dose range that we do use? Lay it bare. It may not be the same dose, it may not be the same frequency, and there are so many other things that may affect the way this medicine will work for you. So it's worthwhile to give it a try. But you should allow the patient, if he doesn't want to use that medicine, there are batteries of medications for every illness in the world today. So you should give the patient an opportunity to change if he's lost confidence in a particular medication, because that in itself is part of the treatment. Confidence in the kind of treatment modality you are offering is also is a determinant of whether he will get well or not. So for me, that is the way I see it. We don't have to insist that it must be chloroquine. We don't have to insist. If he's not happy with chloroquine, then we have to let him know that there are other treatments available for malaria. And there are choices. And you can make a choice out of this. Can you tell me which other ones we have used? Can you tell me what they have done to you? Can you tell me what it has done that you didn't like? So that I can know what to do to prevent it from doing it to you again that same way. So this is the way you go about it. And this is what counseling is all about. Counseling is laying it bare for the patient to be able to make informed, decisions, to choose what he wants. So thank you very much, Mr. Ahmed, for this question.
Thank you so much, Prof. Thank you, Dr. Akintade. We have another question here for Prof. And the person is asking that, what is your take on spiritual exercise, prayers, music, and medication to manage this condition since there's no clear diagnosis? Prof.
Thank you very much. This is a wonderful question. And this is something we talk about every day. You heard me when I was saying that our approach to care today is biopsychosocial. It's biological, psychological, and social. That social is spiritual and social. That social encompasses spiritual approach, cultural approach, traditional approach, milieu, environmental approach, exercise approach. They are all bundled up in that social. So there are many roads that lead to the market. So, and you cannot we cannot say that people who go to churches and receive deliverance do not get relief of their symptoms. They do. Pavlov, in his great experiments, the Russian physiologist, in his great experiments, proved to us that you don't need physical intervention for physiological response to occur. You can condition a physiological response to non-physical approach. In that his wonderful experiment of conditional and unconditional reflex, where he tied certain food or meat to salivation and things like that. So there are so many things that can happen without physical contact, physical interference, that could bring about some physiological changes in our body, including spiritual approach. But the most important thing is that people should know their limits. They should know when spiritual approach will work and when you need something that is more physical. For instance, if somebody has a psychotic illness, he needs medication. Somebody has diabetes, he needs some physical treatment. Of course, you also need some spiritual approach to give him some, confidence, to give him some, internal energy to be able to walk up, to do what he wants to do. So spiritual intervention is allowed, is permissible, and we do recognize how the intervention works. However, we should know the limits. We should know where spiritual approach, can get to, and you will need physical approach, and vice versa. They are all complementary of one another. Thank you very much.
Thank you, Prof. I hope the question has been, answered. And there's a question here from Dr. Tolani Oyerinde, and that's for me. And the question is, why should nursing mother not take Gensomin Eve? Dr. Tolani, thank you so much for this question. And that's because there's no study that has been done on the effects of ginseng on infants, because ginseng could pass through breast milk. So we wouldn't want to get something that gives exertion, that makes boost energy into a child, an infant. There's no study to ascertain that or to back that up. So we are advocating that you don't take as a breastfeeding mother, rather you take a VitaCap, like I mentioned earlier. And you also asked that I should reiterate the prescription. Gensomin or Gensomin Eve is given 1 capsule daily with breakfast, and it should be given. It should be taken for 2 months, after which 1 week wash-off period should be observed. And that wash-off period is for the fat-soluble vitamins that are in Gensomin. We mentioned vitamin E, okay, vitamin A and vitamin D that are present in Gensomin and Gensomin Eve have the tendency to store. So when you give that wash-up period, 1 week, whatever it is that is stored in the body can be used off before you start again, okay? So I hope I'm able to answer your question. Thank you so very much. That's the much at which we can take. So right now, I'll want to have a 1 minute closing remark from Dr. Akintade, as well as Prof, for our listeners this afternoon. And I also want to thank each and every one of us that have made out time. Sorry, Dr. Adedayo Tunji, you're raising your hands. Please kindly, I've allowed you to talk. Kindly unmute yourself and let us hear what you have to say. You've been raising your hand since. So sorry. Dr. Adedayo Olatunji.
Yeah, sorry, I'm sorry. That was an error.
Oh, okay. Thank you so very much. Then we have Dr. Chukunonso also raising his hand. Please kindly unmute yourself. Dr. Chukunonso. Okay, I think that is also in an error. So Dr. Tunji Akintade, please, may we have a closing remark from you, sir?
Well, thank you very much, my able Lagosian, Auntie Oluyemisi, Matti. I want to first of all appreciate Mega Life Science, appreciate Dr. Link, and that the opportunity that has been given, we should continue it and let us share more knowledge among ourselves. I want to advocate that all hands must be on deck. We must be in the medical family. All health workers must work together at this point because what is coming goes beyond personal issues. And we must be able to make ourselves available when the time comes. It is near, it is here, and we are the people that are going to do it. The government cannot lead it. The third one is what I've also requested. I'm glad Prof has said that he has done a lot of work when it comes to mental health. Please don't be tired. We must be able to work and see how we can take advocacy to the states, to the national, and even to the National Assembly to be able to see how we can make it a reality. We've not been able to do an advocacy that actually works. Advocacy on research has not been work. The pharmaceutical world also have to wake up and see that they also do a lot of work concerning that. But I would want to go away today by also listening to Dr. Dankau because Prof has said
yes, so Professor.
He has done something that for you to come across Prof and you didn't take anything home, then I think you have a problem. So if we can be given the opportunity to speak to us in 1 or 2 minutes so that we be able to go. Once again, I want to thank all the listeners and the active participants in this webinar that let us keep it up. The health of Nigeria is going to be better for it. Thank you very much. God bless you.
Thank you, Dr. Akintade. Prof, please, you can unmute yourself and let's hear from you. Thank you so much for honoring the invite.
Thank you very much, Mega Life, Dr. Link, Dr. Akintade. Thank you very much, so much for the presentation. Very, very wonderful. You've given us a lot about chronic fatigue syndrome. Thank you very much for your understanding of multidisciplinary approach to care, not only for chronic fatigue syndrome, but generally in our practice. There is no condition that you have that doesn't have an emotional aspect. I want everybody to listen to this very well. There is no condition that afflicts mankind that doesn't have an emotional aspect, including falling from Okada. It has an emotional aspect. So it's very important that we are very emotionally tuned. We are conscious of other people's emotions. So we cannot be continuously be mechanistic, everything mechanical. We have to be psychologically minded, emotionally oriented to be able to take care of our clients. And I believe we can all do these things. The pharmaceutical companies we want them to support mental health. As I'm talking to you now, there is a bill before the National Assembly. It has gone through 3 readings, including public hearing at the Senate, and it's in the Federal House of Reps awaiting concurrence. It's a mental health bill, a bill that's supposed to change the face of mental health care in Nigeria. So we call on everybody to please support that bill. Support our effort to ensure that that bill becomes a law. The president signs it into law. It's a bill that will force the government to actually do certain things that is contained in the mental health policy that will change the lives of Nigerians. Mental health issue cut across everywhere, cut across ages and social class and educational level. There's nobody that is immune to it. And like I said, there is no condition that doesn't have a mental health aspect. So let's work together. I'm looking forward to Mega Life. This month of May is a month for advocacy for mental health. So I'm looking forward to participating with Mega Life in terms of advocacy for mental health in Nigeria. so that the quality of our care to our patients, the quality of life of Nigerians will be much better. Mental health is with us. We are all experiencing it. We are struggling to survive. I also finally want to say that mental well-being is not a mere absence of mental illness at all. Not like health. Mental well-being, optimal mental well-being is not a mere absence of mental illness. There are people who are not sick, but are not actually enjoying optimal mental well-being. They are just struggling to survive. Many of us are like that. So we need to advocate. We need to let people aware. We need to let people understand what is mental hygiene. We have to encourage people to be able to practice it. Thank you very much again, Mega Life. Thank you, Dr. Ling. Thank you, Dr. Akintade. I'm very grateful. Thanks a lot.
Thank you so much, Prof. We will now have Professor Musa Dankiao, to give us his own word for us today.
Thank you very much, Mega Life. Once again, my appreciation to my friend, my brother, my colleague, Professor Sheikh, TL Sheikh, and Dr. Akintade. Thank you for drawing attention to this very important thing. In fact, in the last set of comments you made, you highlighted one thing I wanted to draw attention to. This topic, I feel, is very, very important, particularly for those of us in the health sector, the issue of care for the caregivers. I have a suspicion that because of our burnout rates among healthcare workers, it's probably a doorway to chronic fatigue syndrome and many other things. And the failure to look at many of these from a biopsychosocial standpoint is up with plenty of people receiving treatment for typhoid over and over again.
Exactly.
For bringing out this, how important it is for us to expect this, how important it is for us to try to identify and diagnose it, and then to work as a team to handle it. This will help not just our patients, but like I said, I believe that quite a lot of healthcare workers are quietly carrying this cross of chronic fatigue syndrome. They are not being effective. They are not being effective to themselves, to their patients, and to us as colleagues. And we need to help each other. Thank you very much.
Back to Matti. Hello. Yeah. Yeah, Tiffany, we are waiting for you.